All three of the iron chelators work very well if the patients take them and the dose is adjusted properly. There are some patients who probably metabolize some of these drugs different than others, and they may be less effective in certain individual patients. But for the most part, they're all effective in removing iron from the body and in protecting from the damage from the toxic form of iron. The deferoprone is somewhat different in that it appears to be much more effective in correcting cardiac function, particularly cardiac ejection fraction or strength of contraction. Only about 2.5% of patients with sickle cell disease develop significant cardiac iron overload, which is quite different than other diseases, so that's less of a problem. But all three are effective. And again, probably more important than the dosing and more important than which drug is adjusting the drugs so that the patients will tolerate them, so it fits their lifestyle, getting them to actually adhere to the prescribed therapy. How to get patients to adhere to the prescribed therapy is a very complicated issue. Part of it is related to the actual side effects of the medications. Desferal, of course, is given by subcutaneous infusion overnight, and it's not difficult to understand why people wouldn't want to do that. It causes pain and swelling at the local site of injection. They have to have an IV hooked up all night. So that has largely been, not completely, but largely been replaced by the oral medications. Deferocerox causes GI gastrointestinal toxicity and has renal side effects. And deferoprone has, in a small percentage of the patients, about 1.3%, can develop significant suppression of the white blood cell count. This side effect, I believe, is greatly overplayed, but nonetheless there have been deaths related to that. So all of the drugs have their side effects. And deferoprone also can cause some gastrointestinal toxicity. So those are all issues. The fact that you have to take a medication every day of your life is also an issue. I personally think a major component of the compliance or adherence issue is the attitude of the providers in the place that's providing the care. And again, this is a rare disease, and iron overload is a rare disorder. So most practices aren't doing this all the time. In a center such as ours, or Oakland, or Philadelphia, where we have over 100 patients that are on transfusions, our nursing staff have all seen patients that are sick from iron overload and have seen them get dramatically better. And so when they say to the patient, "We can get your iron under control," that message is delivered from a point of confidence, and I think that those kinds of interactions turn out to be very, very important. People are always talking about if they're not adherent, then you should have the psychologist see them. Certainly there are psychological issues that are related to any chronic disease. But personally, I think that this positive attitude and projection of hope and can-do kind of a thing, whether it's delivered by the nursing staff or a social worker or a psychologist, is very important and probably better delivered by providers that have a lot of experience and themselves believe and understand that this can be resolved. In my opinion, we can control iron overload in anybody. These drugs are effective by themselves or in combination. The cardiac iron complications can be reversed almost 100% of the time. The damage to the endocrine organs and diabetes and low testosterone and those kinds of things, which are less of a problem in sickle cell disease than they are in thalassemia, but nonetheless are a problem. The ability we can reverse the iron overload. Whether or not the damage from the iron in those organs is permanent or not is not so clear.